All right, so we are recording a lecture today, and one of the things I would encourage you to do is make sure that you know that terminology that we have gone over last week because you will see that again. Your next exam will be your final exam, so we won't have another exam between now and then. I know I told you that we were going to have a quiz today, but I expected a light turnout because of the eclipse, so I did not do a quiz today for rhythm stress. But I can promise you, you will have one on Wednesday. So just kind of review and remember that as far as moving forward. So we've talked about terminology, definitions, and that's really important. So let's talk more about anatomy. Now, when we're talking about the thoracic cavity, we're talking about basically everything from right here down to the bottom of the rib cage and where the diaphragm is. There are a couple of different areas that you need to be aware of, which is basically called the mediastinum and the pleural cavities. The pleural cavities are the area, not the lungs themselves, but it's the area within the thorax where the lungs take up the space, okay? The mediastinum is your heart, your aorta, as well as the superior inferior vena cava. The diaphragm lies down at the bottom, and the diaphragm is actually part of the dividing area between the thorax and the abdominal area. One of the things to kind of keep in mind, especially when you get into advanced trauma that we'll talk about, is that if you have a patient that either has a lower part of the chest that has punctured, has penetrating trauma, or the upper part of the abdomen that has penetrating trauma, some of the bowel that is down here in the abdominal area can actually migrate up into the chest, causing all kinds of problems both for the cardiovascular system, the pulmonary system, as well as for the GI system itself. Within it, we're also going to be talking about the trachea and the esophagus. Remember, the trachea lies closest to the front. That's why, and this will be a skill you'll learn in the advanced sequence, when you go in, you can make a surgical airway. That's why we have access to it. The esophagus lies behind the trachea, and they basically both of them open up at basically about the same spot. The way the body is designed is that we have this little piece of tissue called the epiglottis that when we swallow our secretions or our food or a drink, it flops down over and provides a really, really good seal for the trachea to keep everything out with the exception of air. And so that's important to kind of remember as far as when we're looking at that. Yeah, 12 pairs of ribs. I'm never going to ask you how many pairs of ribs you got, but I am very interested in you understanding, especially from a traumatic perspective of what will happen when you have a fractured rib. Either, again, this is intro to cardiology, especially from a cardiovascular perspective as well. The other thing to keep in mind is that the ribs are attached to the sternum, which is your breastbone, by cartilage. The reason that's important is that helps us to be able to do chest compressions and do them effectively when a patient goes into cardiac arrest. Basically, what we're looking at during CPR is that you have the sternum up here and you have the spinal uh, column back here. Both of them are very bony. The spinal column itself doesn't move, and so when we press down on the sternum, we squeeze the heart, Travis, between the sternum and the vertebral column. That allows us to eject blood, and then much like a sponge or a suction, or like a bellows, when you raise it back up, it pulls blood back in. We'll talk more about cardiac arrest and CPR right towards the end of the semester. The vascular system is really important, okay? And the vascular system is made up of several different components. When we're talking about the vascular system, it is a system of highways that directs blood around the body. Now, the reason that that is important is for several reasons. Number one, it delivers oxygen and it delivers nutrients, primarily glucose, to the cells. Without oxygen and glucose, the cells do not function effectively and will eventually die, thus leading to what we know as a myocardial infarction when we're talking about the heart. The other thing that it does is it removes waste products. Keep in mind that when we're talking about waste products for right now, we're primarily talking about carbon dioxide. Carbon dioxide is developed, it is produced as part of metabolism, and as such, now that is an important finding that we're actually able to measure, and we get lots of good information from that. We utilize a tool that is known as end-tidal CO2 measurement, and you'll learn about how to utilize this both from a numeric perspective as well as from a waveform perspective, much like your EKGs that you've learned in here, which, by the way, I got to tell you guys, you have done probably as well or better on your rhythm strips as any class that I've ever had. So I hope you haven't stopped studying because you don't want that to leak out. Yes?
Are we going to cover any new rhythms?
No. Rhythms are done as far as new rhythms. We'll get a bunch of those when you get into the sequence for those that are coming into the fall or whenever you're coming in, especially when we start looking at 12 leads. Yes?
Do we have a weekly quiz for the module this week?
I don't remember if there is one. I don't think there is. Look online, it will be there because I got them all set up. But as far as our next quiz will be in class on Wednesday for rhythm strips. So, again, end-tidal monitoring is incredibly important. The original purpose of end-tidal CO2 monitoring was to make sure that when we intubated a patient, we had the tube in the trachea, but there's so much more that you can get out of end-tidal than just that. So it is extremely important. When we're looking at the cardiovascular system, you can see the different components of it. As it comes down, basically what it does is the arteries will branch out into smaller arteries that are known as arterioles. And then those tiny arterioles now branch out into capillaries. The capillaries are what surrounds the alveoli, and they also surround the individual cells. That's where, and we'll talk a little bit more about that in a little bit, when gas comes into the alveoli, it's high in oxygen, low in CO2. And through the process of diffusion, it changes place. CO2 comes out of the red blood cell and moves into the alveoli to be exhaled. The oxygen is high in the alveoli, moves into the through the capillary into the red blood cells and attaches to hemoglobin to be sent out to the rest of the body, and then that process is reversed. We'll talk more about that momentarily. When it gets out to the cells, then the process is reversed. Okay, it comes back into venules, and then it comes into veins, which all dump into the inferior vena cava and the superior vena cava. The inferior vena cava drains all the blood back into the heart, from the heart down to your feet. The superior vena cava drains all the blood back into the heart, from the heart up to the top of your head. That whole concept is really important to remember. For right now, when we're talking about the vasculature of the heart, I want you to just right now know that there are two main arteries that branch directly off of the aorta. They're called the left and the right coronary arteries. These arteries get the freshest, most oxygenated blood of any place in the body to perfuse the heart. The oxygen that's going into the heart is actually higher concentration than the oxygen that's going to go into the brain. And so those two arteries branch off. And here's the thing to remember. Those arteries fill during diastole, okay? When the heart is at rest, there's kind of a suctioning process that takes place, and the blood off of the aorta, right at the very base of the aorta, is pulled directly into the left and right left and right coronary arteries. Those coronary arteries will again begin to divide, or new word here that you'll need to know, bifurcate. Bifurcate. Bifurcate is just simply a medical term that means to divide or to junction out. And so the left and the right coronary arteries will bifurcate into other arteries that specifically feed particular portions of the heart muscle. You'll learn more about that as far as when we get into advanced cardiology. So now we've talked a little bit about the anatomy. We've talked a little bit about the physiology. Again, I would encourage you, if you have already taken your anatomy and physiology, or if you're getting ready to take it, make sure that you focus really, really heavily when you get to the section on cardiovascular. Why? Well, obviously I've shared with you that it's my favorite subject to begin with, but that's not the important reason. Every call you run will have some type of an impact on the cardiovascular system. With trauma, you have trauma, you lacerate an artery, you start to bleed. We need to know what impact that's going to have. With sepsis, a massive infection, now what happens is that those arteries will begin to dilate and they'll begin to get leaky. The plasma will begin to seep through the walls of the artery. So, James, what impact will that have on the cardiovascular system? Even diabetic emergencies, having high blood sugars, what impact does that have on the cardiovascular system? So everything that you run into as far as something bad that happens to your patient is always going to involve the heart. So that's why you got to be really, really proficient in it. So let's talk a little bit about pathophysiology, how things take place. Now remember, we talked about myocardial ischemia, and we also talked about myocardial infarction. With myocardial ischemia, you can save the heart muscle, okay? We can pull back. We can keep that tissue from dying off. When we're talking about myocardial infarction, the tissue is dead. It's not coming back. And remember, we talked in here, what are two things that dead heart tissue does not do? And does not conduct electricity, and it contracts. If you only have very good, by the way, Travis, if you only have a very small part of the heart that is dead, the body can adjust. It can accommodate. And many times the heart becomes stronger to offset that. But if you get a critical portion of the heart that dies off, now either your patient's quality of life has been hampered and basically they have to wear oxygen all the time, or especially if a critical portion of the conduction system has been damaged and dies off, your patient goes into sudden cardiac arrest. So again, infarction is dead tissue. Ischemia is oxygen deficient tissue. I used to say oxygen starved, but it's not actually have to be oxygen starved. It just has to be a lower level of oxygen that's going to go in through there. Now, there's a number of reasons why you can have ischemia. Two of the most common ones is going to be because of a blockage resulting in inadequate blood flow due to either plaque and or a clot. Now let's think about how this works. So as we get older, we get exposed to pollutants in the air, we get exposed to stress, we do things to our body that are not the best for it. We overeat, such as I've done most of my life. Maybe we smoke, maybe we have excessive use of alcohol, maybe we utilize some drugs that are not the best for us. All these things can lead into inflammatory response of the heart, of the lining of the arteries. Now remember, the lining of the arteries, when you're born, it is slick. It's like Teflon. Nothing sticking to it. That blood is just flowing around. There's no clot. There's no plaque. Everything is good. Again, as we get older, that begins to change. So inflammation, let me say it to you again, brothers and sisters. Inflammation is the precipitating cause of coronary artery disease. By precipitating cause, I mean that is the initial event that begins to cause patients to have heart disease. So why does inflammation cause such a problem? Think of it this way. Remember I just said that on the lining of the arteries, it's slick. It's like Teflon. Nothing's sticking to it. All that blood is just swishing right up through just the way that it's supposed to be. When we get an inflammatory response, a couple of things happen. Number one is we get swelling. When we get swelling inside an artery, what does it do to the diameter of the artery? And a smaller artery results in what to our blood pressure? It raises it. Perfect. Excellent. So now we begin this really, really negative cascade of events that now our arteries are smaller, but as I say in the infomercial, wait, there's more. It's almost like there's a teeny tiny little man in your artery, and he's got a piece of really rough sandpaper, and he's standing there scraping the insides of your nice, smooth, Teflon-coated artery. Now what's going to happen? Think of it this way. As I've shared with you, I relate things to food. Obviously, it shows. Let's say that your spouse, your significant other, your parent, probably your mom, has this skillet that she loves, and it's Teflon coated. And instead of getting the plastic spatula out, I see you smiling there, you know where I'm going. You get a metal fork out and you start doing this back and forth across her favorite Teflon skillet. Now what's going to happen? Say it again. Things are going to stick. Perfect. The exact same thing happens inside your artery. So once we get that roughening up of the lining of the artery, now we begin to get little pieces of red blood cell that get hung up on it and can't get passed on. What does blood do when it sits? Thank you. Yeah, it does clot. Now, that's bad enough because as it is there, because remember, if you get a cut in your arm and you start to bleed, what happens? Say it again. The blood begins to clot. Well, guess what? That little man that's inside your artery that's scraping, those are little tiny cuts. And the body recognizes that it tries trauma. And so it goes in and it tries to stop that bleeding. So that's where the clots begin. Now, as the inflammation continues to grow, the clot gets bigger. Again, just like you said a while ago, when we have inflammation, the arteries swell, and now the diameter is smaller. But now we've got a blockage in there, and it makes it worse. or as a dear friend of mine from Texas likes to say, more worser. But that's not all that there is. Remember, arteries, high pressure or low pressure? High pressure, okay? As the blood is flowing through and this clot begins to get larger, remember, we have an outer layer of the artery. We have the inner layer. Outer layer is tunica and ventitia. Middle layer, musculaire, tunica media. And the lining of the artery, tunica intima. So if this is the muscular layer, this is the inner layer, and the blood is going this way, eventually the pressure, especially just like you said a while ago, if the pressure continues to go up, eventually it takes that clot and it uses it as kind of a lever, and it now begins to do this. When the lining of the artery begins to separate, now what happens? Say it again. Eventually, if it doesn't stop, you're exactly right. It will result into an aneurysm. But what happens in the meantime? What is happening in that little pocket there? Blood is beginning to accumulate, so the clot gets bigger. We're not done yet. Over time, there is a chemical change in both the lining of the artery and to the blood clot there, and it becomes calcified. Calcified, which sounds like calcium. It is indeed calcium-based. And that, my friends, is exactly what plaque is. So you have blood clots and you have plaque that begins to develop in here. If we were to able to go in and pull out some of the contents of that, and I handed it to you and you rubbed it between your fingers, it would feel just like a teeny tiny little gravel. It is hard as a rock because that's exactly what it is. It's a calcium-based rock. So again, as the pressure continues, now this continues to open up. The clot gets bigger. After a while, if we don't fix the pressure, now we begin to get a really, really big opening, which leads to an aneurysm, which ultimately can lead into a problem with a stroke. The bottom line here is the constriction of the arteries, normally caused by high blood pressure, along with the blockage of the arteries caused by what precipitating factor? Inflammation leads to a blockage in that constricted artery, which you now have less amounts of blood that's able to get around it. It's just like out here on the interstate. We've got 3 lanes from Richmond into Lexington, okay? Traffic is flowing well as long as all the traffic is moving. You get a massive wreck, say a semi wrecks on the Clays Ferry Bridge, 2 left lanes are blocked. What happens to the flow of traffic? It slows down. If people are not watching, guess what happened? They crash into the original crash, and it makes that crash even larger, which leads to more of a constriction on the highway, which leads to that backup of blood. The same thing happens in the heart. Not enough blood getting through, and it begins to back up. Now, there's other things that can come in that can cause this blockage. A blood clot, James, is known as a thrombus. Thrombus. You might want to write that down. Thrombus. A fat particle, okay, a fat particle is known as an embolus. E-M-B-O-L-U-S. So again, not only do we have the blood that now begins to clot on it, not only does it begin to calcify and form plaque, Now we got to worry about increased levels of fat that's circulating through the blood that now grabs onto that and makes the clot even worse. If I remember, I'll try to find an image on internet and let you look at it. One of the most amazing things I ever saw when I first started as a paramedic was that I was doing clinical time in a hospital. We were in a lab and they had drawn blood from a patient that had really, really bad cardiovascular disease, and they spun it down. And on the very top of this, there was this kind of a yellowish looking stuff. I had no idea what that was. And I said, oh, that's all the fat that's in the patient's blood. I mean, it was gross. And it's kind of like, oh, that's not good. Okay. And so that fat is in there, and that leads into the blockage as well. The bottom line here is that the size of the artery gets smaller. The smaller the artery, the less amount of blood that can get through. The less, especially when we're talking about either the heart or the brain, the less amount of blood that gets through, the less oxygen gets through, which leads into ischemia coming into play there. Now, we talked a little bit sometime back about Prinzmetal's angina. Does anybody remember what causes Prinzmetal's angina?
Angina's pain.
So it is pain. So Prinzmetal's angina, is, I would assume Prinzmetal is probably the name of a physician that discovered this, is that it's caused by a vasospasm of the artery. I would suspect everybody in here at some point in time has had a cramp, okay, and it hurts. It's immobilizing. And basically everything just kind of constricts in the muscle, Carson, when you have that cramp. Now, what happens is in the artery, remember, the middle layer of the artery is made up of what? Muscle, okay? Anywhere you have muscle, you can also have a cramp or a spasm. A spasm in one of the vasculature, the artery or the vein, more commonly in the artery, is known as a vasospasm. Vasospasm. And now what happens, Carson, is that artery will constrict down so tight, so small, that there's not enough blood getting through, especially into the coronary arteries, to feed the heart. The end result for this is what for our patient? If there's, regardless of whether it's a blockage from fat, blood, and plaque, or if it's caused by a vasospasm, the end result is what? Say it again? Pain as a result of what, though, Travis?
Well, spasm in that case. The muscles cramping.
True. But what's not getting through?
Oxygen.
Oxygenated blood. Yeah, oxygenated blood. That's leading into ischemia, leading into that pain or discomfort that your patient is having. The most common cause of vasospasm is use and abuse of methamphetamines. Remember, methamphetamines stimulate the sympathetic nervous system. One of the things that the sympathetic nervous system does when it's been stimulated is a vasculature will clamp down. And so when a patient takes a large amount of meth, cocaine, crack, whatever their flavor is, now they can have that vasospasm, which leads into, number one, the same kind of pain that your patient is going to have when they're having angina as a result of a blockage. But it's not because there's a blockage, it's because the diameter of the vessel is too small. We normally see this in younger patients, younger than the age of 30. Why? Because patients who use a lot of meth generally don't last beyond their 40s. They'll die of some type of cardiac issue or an overdose that comes into play there. Now, when we're looking at these patients, one of the things that we want to be able to look at is some of the things that are leading into this. So we've kind of already talked about a coronary thrombosis. Now, what did I tell you a thrombus was just a second ago? It's a blood clot. It's a blood clot. So again, as we're going through here, I want to take us just a little bit deeper into the pathophysiology of what happens in a blood clot. So generally what we're looking at here, you can see as it says you see plaque that begins to form on the inner wall of an artery, okay? And this is primarily going to be caused by what? What leads to this? What's the precipitating cause? Inflammation, the precipitating, the initial, the starting cause of this is going to be inflammation. Again, this can come about as a result of high blood pressure, lack of exercise, smoking, vaping, genetics, diabetes. All those things can lead into that process. Basically, it gets roughed up, and now we begin to get this that is just beginning to form in there. The next thing that happens now is that at a certain point, it gets torn. And now the body recognizes that as we have a laceration. We have a situation in which we have to stop bleeding. So we send platelets. Platelets are the part of the blood that get really, really sticky when there's a laceration. There's certain chemicals that are excreted by the body. We'll learn more about that in advanced cardiology. But suffice it to say for right now, the platelets get really, really sticky. And they begin to stick to each other, and they begin to stick to the rough part of the arterial wall. Okay? This starts where the clot is now going to begin to develop. The other thing that happens, next time that you get a cut or a bump or a scratch where you've got a little bit of blood that has developed, let that blood clot, let it form a scab, and then if you can either take your iPhone, or if you've got a small magnifying glass, take it and look at it, because you'll see some strands. It looks like teeny tiny little pieces of thread that wind through that scab or through that clot. That is known as a substance called fibrin. 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 It's part of the clotting process, and it's a good thing, especially in trauma. So the platelets begin to stick together, and then the body secretes a chemical that makes fibrin that puts a net around these clots to, number one, hold them together, and number two, to hold it in place wherever the laceration is. This is why when I cut myself of a morning, I don't bleed to death. It forms a clot and it stops. This is why when a person gets shot in the liver or the spleen, the body tries to clot it off. And this is the whole process that occurs. So it's a good thing in the presence of trauma, not such a good thing in the presence of cardiac disease. Now, at this point in time, because again, we have inflammation, which reduces the size of the artery, and now we've got this plaque, fat, and clot that's beginning to develop, the diameter of the artery is even smaller, which is going to do what to the pressure at that point of the artery? Raise it or lower it? It's going to raise it. Remember, high blood pressure, uncontrolled, not a good thing. It makes the inflammatory process worse. And so we can actually, just by having high blood pressure, make this clot even worse. As that clot is there, it reduces the amount of oxygenated blood that can get by it. It's just like we talked about out here on the Clays Ferry Bridge. You get a semi that wrecks and it blocks off the left lane. You still got two lanes that cars and stuff can get through. But if you have multiple semis that wreck, you'll either have two lanes that are blocked off with one lane that's allowing to get through and it's diminished greatly, or worst case scenario, it blocks the entire bridge off and nothing gets through. Same thing happens in the heart. So when we have a diminished amount of blood that's getting through, that's known as ischemia. We're still getting some oxygenated blood through, Carson, but not enough. This leads to that pain or discomfort that Travis was talking about a moment ago. When we have a complete blockage in the heart, this leads to infarction or necrosis. Two words meaning the same thing. Dead tissue. Okay? And nothing is going to get through. Now, we've got to act quickly to help take care of our patient. Because again, the mantra you want to remember when you're dealing with strokes or heart attacks is time equals muscle. The more time that goes by that we have a complete blockage, the more muscle that dies off. Muscle in the heart, muscle in the brain does not regenerate. When it dies, it's gone, and it's gone forever. It does not come back. At some point in time here, we begin to see where the oxygenation is diminished enough so that if the patient is sitting still, remember, it's kind of a law and supply and demand. If I'm sitting still and I've got a blockage, okay, I'll be fine. I've got enough going through. My heart's not having to work that hard. Heart rate is down. But if I get up and I walk, or if I'm under stress, or I try to exercise, now my muscles need more blood. The heart senses that. It begins to beat faster. And as a result of that, the workload of the heart goes up, which means it needs more oxygen, but it can't be supplied. And so this is where we begin to have discomfort. I like to describe it as discomfort because when you're doing your assessment on your patients, Naomi, your patients will give you 10, 15 different descriptions of what it feels like in their chest. Sometimes they'll say, it hurts, it's painful. Other times they'll say, well, it's a full feeling, or I have pressure, or I feel like I've got an elephant sitting on my chest, or I feel like I got a rope around my chest and two people are pulling it out in opposite directions. And so that's why when you ask your patient, don't ask them, are you hurting? Because they'll answer yes or no. Because if I got a little bit of pressure in my chest, it's kind of, it's not really hurting. A little pressure, but it's not hurting. Always ask them open-ended questions of saying, well, tell me how you feel. Let them use their words to tell you what's going on in their body, okay? Now, atherosclerosis. Atherosclerosis is this whole disease process that we just talked about. Inflammation leading to swelling, leading to reduced diameter because of the swelling, leading to roughening of the lining of the artery, resulting in fat, clots, plaque being deposited there, leading to it beginning to separate, and more fat, clots, and plaque being deposited, resulting in a reduction in the lumen of the artery up to including a complete blockage. In this particular situation, what we're looking at here is what we talked about a little while ago when we were talking about Prinzmetal's angina. What this leads into now is a condition that's known as angina pectoris or angina pectoris, whichever one you want to call it. Basically, it means that the demand for oxygen is greater than the supply. Think of it this way. Let's say you're working, okay? It amazes me, continually amazes me. I just talked to one of my medic students today that she's a full-time student and she's working 2 part-time EMS jobs. It's kind of like when people say today that your generation is lazy, they haven't met y'all. Trust me, I brag on y'all on a regular basis because I'm trying to dispel that myth. But let's say that you're working, okay, and you've got your budget all set up for housing, car, food, social activities, vacations, and your income over here is meeting all of that, okay? And you're comfortable. Life is good. You enjoy it. But let's say that now, instead of working 40 hours, your hours get cut. They get cut to 20. What's that going to mean for you as far as your budget? It's going to decrease. And what are you going to have to do? Can't work more. Let's just say, for whatever reason, for the scenario, 20 hours is as much as you can work. What are you going to have to do? You're going to have to spend less. Go ahead, Jim. You're going to have to cut back on the expenses. Let me ask you a question. How's that going to feel? It's going to suck, isn't it? I'd planned a really nice vacation. My hours just got cut. I can't go. I'm not happy. Same thing happens in the heart. When you have a blockage in the heart and it reduces the amount of blood's going this way, it reduces the amount of blood that's getting over to your heart tissue, the heart begins to suffer. It begins to have discomfort. It does not feel good, just like you and I would be if our hours got cut and we had no other way of making it up. So what we have to do is we have to fix that, okay? We have to go in. And we can do things like that by either having our patient to rest. We can give them some oxygen when it's appropriate. We can give them a drug that's called nitroglycerin. All three of those things you're going to learn about. Here's the thing to remember. Patients who suffer from angina are at a much higher risk of having a heart attack than patients who do not. Why is that? They already have the blockages. They're already beginning to have symptoms. Many times, this first onset of this anginal pain is their first indication that, Houston, we got a problem. It's here in the heart. We got a blockage. Again, because of reduced blood flow. Okay? Now, again, so that comes about from the blockage. And I'm not going to go deep into this one, but we already talked about vasospasm. And remember, Prinzmetal's angina primarily caused by the use of what? Meth. Okay? Now, here's the thing to remember, ladies and gentlemen. Not all chest pain is cardiac related. If you've ever gone out and played football, basketball, or even softball or baseball and you've gotten hit in the chest, you know that it's sore. It hurts and you can have chest pain. Sometimes you can even have a shoulder injury, or if you tear a rotator cuff, that pain will radiate into your chest as well. So again, not all chest pain is cardiac. How do we help us to identify when it is and it is not? Two ways here. This is not conclusive, okay? But this is two ways that will help you to kind of classify and say, yeah, I think this could be a heart related, or no, I'm pretty sure it's not. Number one is that if you press on the patient's chest and it hurts more, that's probably not cardiac. That's probably what? Not shock. Muscle, okay? Or it could be skeletal, okay? Anybody in here ever had either a fractured or a bruised rib? How'd that feel for you? Not good. You're exactly right. And why? Because you've grown accustomed to this thing you like to keep doing called breathing. And every time you breathe, Surges, I'm thinking of motorcycles. Travis, every time you breathe, you expand your rib cage, and that fracture moves and it hurts. Okay, so if you press on this, or if you ask your patient to move and he or she says, "Oh yeah, it hurts really bad there," if I come back here and I say just like this, it goes completely away. Or if you ask them to take a deep breath in, that's probably not cardiac. It's more either number one, musculoskeletal, or number two, as what I've been doing for the last couple of weeks, I cough a lot. My chest is sore. Why? Because in coughing, I stretch chest wall muscles, or I get an infection in my lungs. And so when I inflate my lungs, it hurts. Now, that is not 100% conclusive. So whatever you do, don't hear Dr. Young say, "Oh, if he's moving or if he's breathing and the pain gets worse, it's not cardiac." Because remember, your patients have not read your book, so they don't know how they're supposed to act. So you can have a patient that has a chest wall injury and having a heart attack. You can actually have some abdominal problems. If you've got a patient that has gallbladder disease, I don't know if anybody's ever had a gallbladder attack. I had one once. Thought I was having a heart attack and went to the ER. Found out I had a bad gallbladder. But it will hurt up into your chest, a lot to your right shoulder. And so you can have abdominal problems. Pancreatitis, inflammation of the pancreas, can radiate up into your chest as well, leading to chest pain. Again, you and I as paramedics, we're not going to be able to differentiate that. That's going to take somebody higher on the food chain. The other thing that we look at here would be psychogenic type of problems. Basically, the patient is having an anxiety attack. And as a result of that anxiety attack, they're having chest pain. Okay? That pain is real to them. Don't just blow off someone who's having an anxiety attack because a number, or hyperventilating. There's a number of organic reasons. They could have overdosed on a medication, such as aspirin. You get a patient that's taking a bunch of aspirin, they become really acidotic, and they start breathing really fast, but they can also begin to have some chest pain. So we have to kind of keep that in mind when you're going through that hard drive in your brain and you're developing what's called a differential diagnosis. Your differential diagnosis is saying, could be this, could be this, could be this, could be this. Now I've got what my differential diagnoses are. Let's see which one that I think it is most likely, and you assign a weight to each one of them, okay? So if you've got, could be chest wall injury because the guy's been involved in a car wreck, but then again, the guy is like 55 and overweight, and he says his chest was hurting before the wreck. It's kind of like, now it could be chest wall injury, and it could be cardiac. So again, your patients don't come boxed up with just single types of diagnoses, okay? So acute coronary syndrome is the umbrella term for heart attack or cardiovascular disease. It can lead into hypertension, it can lead into stroke, it can lead into heart attack. Now, again, when we've got a patient that is having an acute myocardial infarction, again, somebody remind me, break down the two words or the three words, acute myocardial infarction. One. Good. Myocardial. Heart muscle. Infarction. Death of tissue. So this is a sudden onset of death of tissue of the myocardial, myo, muscle, cardial, heart, tissue, okay? It's a heart attack. We use proper terminology in here. Now, again, when you've seen one person having an MI, you've seen one person having an MI. Patients' discomfort can range from all different types of things, from pain to pressure to nausea to vomiting to shortness of breath to weakness to dizziness to anxiety. Two of the things I want to stress to you right now, and you will hear me say this repeatedly in all my cardiac classes, is you got to understand, ladies, y'all don't play fair, because it used to be thought women did not have cardiac disease. It was a man's disease. But then they began to realize females do indeed have cardiac disease, and you have it at the same rate as do men. But your symptoms are often, not always, but often entirely different. I think we kind of talked about this in a little bit. What is the hallmark sign or symptom that we see with females or diabetics that often indicates that they're having a heart attack? Tiredness that is what? Without a cause. So if your patient looks at you, and your patient is a female or a diabetic, and especially, James, if your patient is a female and a diabetic, and they say, Paramedic James, I am tired. And it just started. Remember, it's acute. It's a sudden onset. It's not a gradual onset here. But they say, I was fine up until about 15 minutes ago, and now I'm so tired I can't even raise my arms. Okay? I want a little Dr. Young pop up on your shoulder and go, check her for an MI. Let me tell you what happened not long ago. One of my sequence students, the paramedic sequence students right now, literally had a 45-year-old woman whose chief complaint was nausea and fatigue. Sudden onset. They did a 12 lead on her. Found she was, because the student remembered, because I beat this into all y'all's heads. The student remembered, hey, Dr. Young said we need to check for an MI. They did a 12 lead. Guess what? She was having a massive MI. Guess what? She arrested on the way to the hospital. Guess what? They resuscitated her, and today that lady is back home with her family. So again, remember that. Yes, sir.
I just have a question. Like, if you do find out that they are having a heart attack, how would you report that to them? Would you say anything?
Okay, very good. Here's the thing you want to do. I would strongly encourage you, and this is not directly related to cardiology, but it is very much important and related to healthcare. There's a book out by a psychologist by the name of Daniel Goleman, Goleman, called Emotional Intelligence. Emotional Intelligence. It's a very easy read. It is not full of psychological jargon, but it is written for the layperson. And in that book, he talks about us, in another word, being able to read the room and recognize that if you're having a heart attack and you're having a heart attack, I may approach how I'm going to tell you differently than I'm going to tell you, just depending upon how you're reacting. Never lie to your patients. Never, ever tell them you're not going to die. Well, guess what, folks? To my knowledge, everybody dies, okay? And so when you're dealing this, if you've identified the patient that's having a heart attack, tell them, well, it looks like, Mr. Smith, based on your symptoms, and it looks like on your EKG that you are indeed having a heart attack, but, and you got to follow this up really, really quickly, but I promise you I am going to give you the best care between now and the time that I get you to the hospital. And this is what we're going to do. What that does is it instills confidence in you as a health care giver. Now, why is that important? This does have a direct impact into cardiology. having that confidence and having that person to be able to trust you goes way beyond just a public relations thing, which is nice. But if I'm having a heart attack and you show up, and I'm going to think, oh, great, I know who his cardiology instructor was. No, I'm just joking. But if you show up and you are showing, you're being honest with me, and you are showing compassion to me, and you're maintaining control of the moment, what's going to happen to me emotionally?
You're gonna feel secure, so you're gonna be more calm. You're not gonna panic.
What's going to happen to my sympathetic nervous system when I feel calm and I'm not going to panic?
It's gonna settle. It's not gonna cause you to.
That's where your medicine begins. Before you give the first aspirin, before you give the first nitroglycerin, before you give that first injection of pain medicine, that's exactly right. So again, how do you do this? You act compassionate. I will tell you, there will be some days it will require every muscle of your fiber. You're going to be tired. You're going to have problems at home. You're going to have problems with your significant other. At some point in time, y'all are going to have kids. You're going to have problems with the kids, with the dogs, with the bills. But you got to turn that off for just a little bit of time and focus in on your patient. Because, again, it's just like you said, James, I'm going to have confidence in you. I'm going to go, well, he's not freaking out. Well, if he doesn't freak out, I don't need to freak out. There have been several times I've been on a plane and it's kind of like, this doesn't feel right. So immediately what I always do is I look to the flight attendants. And out there they are. They're pouring drinks and pouring coffee and Coke and handing out snacks. And it's kind of like, okay, if they're able to do that, then apparently this is just normal. And so it's going to lower my sympathetic nervous system, which means what for my heart? I'll come right to you. But if I lower the sympathetic nervous system, what does that mean for my heart?
Relax.
What else does it mean? I relax. What else does it mean? Decreased cardiac output and demand. Okay? So the heart doesn't need as much. It's the same way as if I get up and I run, and if I'm running, shoot the guy behind me, okay? I don't run. But if I'm running, I'm going to have some shortness of breath, but if I sit down, it goes away and I'm fine. The same thing happens if you're truthful and compassionate. James.
It's going back to what you always say. The patient has more attention. Relax. You're a professional. It's like when you would go see a doctor, you would trust the doctor.
Yeah.
Same with being calm and professional.
Yeah.
At the same time, it's the same thing as being just a.
Absolutely. Yeah. I don't know how y'all act when you're out of here. None of my business.
Poorly. I'd rather not.
Don't mess up my image of you all, okay? But I really like this class because you're attentive. Even when you're sleepy, you don't snore. I like that. You ask questions. Monday's always kind of rough, and I understand it. But you've got the good basis of being a healthcare provider. And folks, that's part of the problem with healthcare in America today is that people just don't care. And so that caring part is going to be really, really important for you. All right? We're going to stop there.